Joint replacement surgery is, without a doubt, one of the biggest success stories in modern medicine. In this explainer, we're going to deconstruct the core principles to give you a really solid framework for understanding this incredibly common and truly life-changing procedure.
All right, so here's the game plan. We'll start with the foundational principles. Then we'll get into the different types of arthropathy. From there, we'll put a spotlight on the hip and the knee, dig into the materials that make it all possible, and then wrap everything up with the key take-home messages you'll want to remember.
Okay, let's kick things off with the big why. Why do patients even need joint replacements to begin with? Understanding that clinical context is absolutely fundamental to grasping the principles of arthroplasty.
So, the number one reason we're even talking about this? It all comes down to advanced osteoarthritis. This procedure, endoprosthesis, is really the definitive end-of-the-line treatment when all the conservative measures have failed and the patient's pain and loss of function are just destroying their quality of life. Okay, so once the decision for surgery is made, what's the first major fork in the road? Well, it's all about how much of the joint we actually need to replace. And that brings us to this fundamental split between a hemiarthroplasty and a total arthroplasty.
And this really breaks it down for us. In a hemiarthroplasty, hemi meaning half, we're just replacing one side of the joint. The classic example is replacing only the femoral head after a hip fracture. In a total joint arthroplasty, as the name implies, we're replacing both sides of the articulation, so both the ball and the socket.
All right, let's take these concepts and see how they play out in one of the most common replacements, the hip. We're going to deconstruct the total hip arthroplasty, or THA, and look at its components and, just as importantly, how we fix them in place. So how do we actually get these implants to stick to the bone? Well, we've got three main strategies. We can use a special bone cement for rock-solid fixation right away, which is great for older patients who might have weaker bone. The second option is an uncemented or press-fit component, where the implant has a rough surface that the patient's own bone actually grows into over time, perfect for younger, more active folks. And a hybrid? Well, that's just a mix of the two. Now, regardless of how you fix it in place, every total hip replacement is built from these three core parts. You've got the acetabular cup, which becomes the new socket. You have the femoral stem, which goes down into the femur. And finally, the head, which sits on the stem and creates the new ball for that ball and socket joint. Awesome. So we've got the hip down. Now let's pivot and look at its counterpart, the knee. We'll break down the types and components of a total knee arthroplasty, or TKA, and see how it tackles the unique biomechanics of this complex joint.
And you'll see a really similar thought process here as with the hip. A total knee arthroplasty, or TKA, resurfaces the entire joint. But if the arthritis is only in one part of the knee, we can do a unicompartmental replacement instead. The core components are the femoral component, a tibial component or tray, and sometimes an optional button for the patella.
Okay, this is where things get really cool, in my opinion. We're diving into the material science. The choice of the bearing surface, that is, the two parts that actually rub against each other, is absolutely critical for how long these implants last and how well they function.
So, for those uncemented implants to work, you need the bone to literally grab onto it and make it part of the body. How do we do that? Well, we use biocompatible materials like titanium, and then we coat the surface with something osteoinductive like hydroxyapatite. This coating basically tricks the bone into growing right onto the implant, creating an incredibly strong biological bond. This table is super helpful because it lays out the options side by side. And what I want you to notice right away is the huge difference between what's available for the hip versus the knee. For hips, we have multiple options, like super hard, low-wear ceramic on ceramic. But for the knee, it's almost always a metal femoral component rubbing on a special type of plastic, an ultra-high-molecular-weight-polyethylene, or UHMWPE insert. All right, we have covered a ton of ground, so let's boil this all down to the absolute must-know high-yield points for your rotations and, of course, for your exams. So if you walk away with anything, let it be this. Arthroplasty? That's your go-to for end-stage OA. First question, are we replacing one side, a hemi, or both sides, a total? For the hip, you've got three ways to fix it in place. For the knee, you can go total or just replace one compartment. And finally, and this is key, the bearing surface options for the hip are way more varied than for the knee, which almost always uses metal on poly. And I want to leave you with a clinical question to chew on, something that really gets at the heart of surgical decision-making. When you're looking at a total hip,
What factors might make a surgeon choose, say, a hard-on-hard ceramic bearing versus a more traditional metal-on-polyethylene one? Start thinking about the patient in front of you, their age, how active they are, their bone quality. That's where modern arthroplasty gets really interesting.